Welcome to another episode of our In Conversation live series. Today we're in conversation with Dr. Biren Nadkarni, Senior Consultant Orthopedic Surgeon at Sitaram Bhartiya Institute of Science and Research. Dr. Biren has nearly 20 years of experience in orthopedics and has frequently been seen in the media for his insights on bone and joint care. Dr. Biren has a vast experience in terms of joint replacement, including knee replacement, which is why today we're going to talk to him about knee replacement, fact versus fiction. Welcome, Dr. Biren.
Thank you, Sachin. Thank you so much.
So, Dr. Biren, to begin with, we've come across a lot of people who are considering knee replacement because of the severe pain in their knees, but they're not sure because they have some or the other myth or concern which sort of, prevents them from going for a knee replacement directly. Some of these myths often or fears often revolve around alternative types of treatment for knee pain. Say, for example, sometimes people often believe that injections or herbal oils can help cure painful knees. In your opinion, to what extent is this true?
And second is the herbal oils. So I'll tackle the injection first. We are doing about three kinds of injections for knee osteoarthritis. The first is steroid, second is viscose supplementation, and third is recently picked up, which is PRP, platelet-rich plasma. Steroids, the indication is purely for an inflamed knee, which is full of effusion, there's a lot of swelling, and basically we are doing it for reducing the inflammation. And as we know, steroids are the most potent anti-inflammatories. The effect is going to last for about 4 to 6 weeks, maybe 3 months. And steroids per se have a deleterious effect on the long-term health of the cartilage. So it cannot be a treatment modality for long. It is only to take care of the inflammation. And if at all somebody has to take steroids just to prevent any other surgical thing, then he has to take it not more than 4 times a year. Coming to viscose supplementation, the second injection in which we inject some substance called hyaluronan, which is basically the building block of the cartilage, and it helps strengthen the cartilage strength. All companies, Indian and multinational, they have been into this, and it is good for early grade 1, grade 2, or even very early grade 3 arthritis. And these give effects for about 6 months. So there is a possibility of people coming back after that to get repeat injections. PRP is taking your own blood sample, centrifugating it, getting a concentrate of platelets, and injecting it back into the knee. Indications are almost the same as the second category of viscose supplementation, but of late results have been better with PRP as compared to viscose supplementation. There are various modes of preparation of this injection, each technique being different from the other. And coming to the herbal oils, as we understand, is they are basically counter irritants. Counter irritation is a process in which you create a superficial inflammation to take care of the inflammation somewhere deep inside. So they will not take care of the cartilage, they will not regenerate the cartilage, yes, but they might give you some pain relief for some time.
All right, so I think that was explained well in terms of, say, all of these methods. I guess what I understand is that they're relatively short term. So they might have a role to play in the beginning, but maybe not for very severe knee pain. Sir, so then is there any specific age or stage at which you recommend knee replacement surgery?
So age is a big criteria. It used to be a big criteria earlier because early we had put like a chronological age of 60 years. But I would say it is more than the number, it is the disability which matters more. With modern lifestyles, we see a lot of younger patients coming who have the same arthritis as an older person would be having at 65, 70. So age per se is not a criteria, but if at all we have to put age, I would say somewhere between 55 and 60. And the reasons are very simple. The implant you're going to put or implant you're going to insert has a longevity profile of maybe 15 to 20, or for some special materials as long as 25 to 30 years. So you would want to implant a knee and you want to forget about it, not come back again to do a revision surgery if at all this implant gets used or it creates a problem later on. Staging, grading, there are 4 grades of osteoarthritis starting from grade 1, which is minimal damage to the joint. In fact, some people actually miss the phase 1 or the grade 1 because they do not feel so much pain. And Our patients are mostly, they take their pain very well. They normally present to you at very later stages, sometimes at grade 2, sometimes at grade 3. And so, of course, initial treatment has to be non-steroidal anti-inflammatory drugs. There has to be injections. There has to be topical analgesics, and a holistic management with physiotherapy, exercise, management of the quadriceps and the hip exercises there. And if at all things do not improve on that, then only we suggest that each person should consider knee replacement.
All right, sir. That was a fair explanation of the stages that you said. So, sir, also there is a fear, a certain fear that people have during surgery and also after surgery. They feel that there will be a lot of pain involved. In your opinion, again, in your experience, what are the techniques that we use in terms of any pain relief methods that you could maybe talk about to help sort of lessen this pain?
You're absolutely right. Pain is a big factor. A lot of people, a lot of patients coming to us wanting the procedure, but they have all heard from their peers and everybody that it is a painful procedure. And I will not deny that we cannot say that we can be totally pain free. But with modern techniques, we have reduced the pain from maybe at least by 70 to 80%. And the reasons are use of newer techniques of pain control. So pain control was always like attack pain after the pain occurs. So once the abnormal sensation starts and you start tackling it with pain medications, you lose the benefit. So now we are going for preemptive analgesia. You attack it before the pain starts. So most of our, in fact, not most, everybody of our joint replacements, knee and hip, they are started on pain medications 3 to 5 days prior to their admissions. So they have a preemptive effect on the pain control. During the anesthesia, during the surgery, we are using a combination of spinal and epidural anesthesia. After the epidural anesthesia, we leave an indwelling catheter, which delivers the injection, the local anesthetic to the spinal cord, and ultimately people feel pain-free. And this is done at a level where their muscle control is not lost. It is only the sensory part which is taken care of. We have even gone a step forward and we are using perineural nerve blocks. Our anesthesia team is very adept at that, and they are using ultrasound guided pain control techniques by using adductor canal blocks, which is only numbing the nerve which is involved around that region. During the surgery, we use a combination of local anesthetic, opioid analgesic, antibiotic, and we inject it after we have done the procedure along different sites in the joint. And this takes care of the pain control for next 16 to 18 to 24 hours, depending on the mixture. Non-diabetics, we also add sometimes a small steroid dose in that. So pain is taken care of by that. And this technique of using multiple modes is called multimodal analgesia. Multimodal analgesia means using multiple techniques, multiple ways of administering different drugs using different pain pathways. So people feel relatively pain-free. In fact, our stay in the hospital has reduced a lot. What people used to stay for 6 to 7 days after a bilateral knee or a single knee replacement, it is almost as down as 3 to 4 days.
All right, sir. So again, quite a few points that you've covered there in terms of reducing the pain by about 70 to 80%. That's a lot. So I think that's that will put a lot of people at ease in that sense. Also, the duration of the hospital stay, again, if that's come down from 6 to about 3 to 4 days, then I think that's also something that a lot of people can take note of, especially if they are considering knee replacement surgery. So we've also gotten a few questions from the audience. There is a question related to a few points that were just covered. There is a question from Praveen. He says, "What is minimally invasive knee replacement surgery?" So if you could maybe explain that a little bit.
So minimally invasive, as the name suggests, is less invasion. We are violating the soft tissues, the muscles, the skin less as compared to a traditional knee replacement. So traditional knee replacement involved an incision of as long as 6 to 8 inches, which is about 15 to 18 centimeters initially. We can see them in the patients who come now. Now the incision length has gone to about 4 to 5 inches, but it is not only the length of the incision we use. It is more about less violation of the muscle tissue. So earlier we used to violate the quadriceps, the front tendon of the muscle, to reach the joint. Now we avoid that and we go through a technique called quadriceps sparing approach, which is basically going through a vastus medius VMO, which is basically a side muscle of that. And once you do that, you are actually adding less damage to the muscles, you are adding less tissue damage to the patient, and the patient has less pain, less bleeding, and everything is less. So the pain is basically a function of the tissue damage which happens during the surgery. Surgery is anyway is a surgical stress. So if any by any chance we can reduce that stress, we are aiding the patient by contributing less to the pain, less to the bleeding, and less to the discomfort after the surgery.
All right, sir. Sir, there is another question from Sangamitra. Actually, there are two questions. One is whether the surgery is successful at the age of 75. We've covered age a little bit before, but if you can talk about, whether there are any maybe risks also as the patient gets older. And the other question I'll take up after this question.
So it's a vicious cycle. People think that life expectancy of Indian patients has gone up since the time we gained independence. It is as good as 69 to 70 for ladies and 62 to 63 for males. And with increasing life expectancy, we are seeing patients outliving their normal life expectancy, which used to happen earlier. So we see a lot of patients who postpone their initial decisions of having the surgery, thinking that it's a very simple thing. They think that they might not last that long or something like that. But patients do take a call at 70, 75 that they now are in a dire need of that procedure. So with modern anesthesia techniques, age is just a number. Mostly patients it is more about the physiological age, their cardiac status, their heart status and their lung status. Everything has to be worked up before. I can only say for a younger patient where we could basically plan for both knees at one single situation, one single time, a simultaneous knee replacement. For people like these who are above 70, we would like to go gingerly with a soft touch, one by one, and give a gap of at least 3 to 4 months between both the knee replacements, and prime up and give a good psychological evaluation and a good psychological counseling of these patients before the surgery and during the surgery. The expectation should be very realistic. Knee replacement is just a resurfacing procedure wherein you add some metallic parts to the cut ends of the bone. You remove the old and the disheveled part and you put new implants into that. So basically, replacement is a misnomer. It's actually a resurfacing procedure. It's like your tooth gives away and you put a cap on that. So it's just like a capping procedure. But your muscles, your soft tissues, your ligaments are still the same. So ultimately, you have to work on that, and you have to improve the efficiency of these muscles by good exercise. Good exercise doesn't have to start only after the surgery. It can start as early as before the surgery, and it continues after the surgery. So yes, you can go ahead at 75. Oldest we have operated is 95. So if you think 75, but it's not a number. It's not a great fun in telling this. 1995 is a great age. Ideally, the age when it was designed was as good as about 60, 65, the age, chronological age when it was to be done. But ages can be managed by a good amount of counseling and good amount of anesthetic work.
All right, so what you said about operating on a 95-year-old, that's still I mean that's a great achievement, I guess. And also, sir, when we talk about expectations, I agree with you. It is important to clear those expectations from the beginning. Sir, in that same line of thought, we have another question from Shifali. She says, "What is the success rate of this surgery for a 50-year-old woman?"
So I would say a 50-year-old woman, we see arthritis in females earlier than males. And it has a lot to do with the postmenopausal changes they go at the same time. So I would like to know a 50-year-old if she has gone for a knee replacement. Uh, has she had a surgical menopause or a hysterectomy? Has there been a hormonal issue? I would like to know if she's been osteoporotic along with that. And for a 50-year-old, I would, rather than be using a standard implant, my implant is mostly implants are cobalt chrome. This is a alloy. For a 60-year-old, 50-year-old lady, I would like to use a a better implant which has a longevity as good as 25 to 30 years. And there are companies, international companies, which are offering these implants because the whole purpose is to operate once, to operate it best, and try not to go inside again unless until there are some other complications with the joint. So yes, we can do, but the implant and the usage and the choice of implant differs in such patients. So for somebody, if you ask me what is the longevity of implant, I can say the longevity of implant after it is inserted is about 90% of all implants. They last between 15 to 20 years of the index procedure. So it's never exact numbers. It's a range where we see that. And this is how the registries are the combinations of all the replacements which have been done. They are piled up and every data comes out from there. India, we do not have a good system, but Scandinavia, Australia, Britain, they all publish the registries and we get our data from there. So this is how it is.
All right, sir. So there is a follow-up question from Shifali. So she says that in the woman that she was referring to, there are no hormonal issues, but I think the weight is on the heavier side. So does that also, play a role, something that should be looked into?
So we look at weight and BMI. We think BMI is a good way to see the weight. We know that India is the diabetes and obesity capital of the world, and and our obesity is different from the world's obesity. We are more of abdominal fat, more of visceral, and this is what creates a problem. So there are a lot of people who ask us that should we lose weight first and then come for the replacement. I think this is what the question is all about. And how do you lose weight? You lose weight by going for walks, for exercises, which people are not able to do because of the pain in the joints. So ultimately, it's a vicious cycle. You have to break the cycle. Yes, somebody who's morbidly obese, BMI more than maybe 35, would be a good rule for a good candidate for a bariatric first. But most of our patients, once they go for the replacement, if not twice, to simultaneous replacements one by one, if at all both these are involved, they lose weight after the surgery. So we have seen this very often that patients, once they get mobile after the surgery, when they start walking, their activities increase, they tend to increase, and they tend to decrease their weight. So the BMI normalizes mostly.
Okay, all right. That is a good point that you've put up, sir. And actually, also thank you, Shifali, for bringing up the question because that is something that we don't really hear often, and this is a common concern. So there is a question again from Sangamitra. She says, "Do can curved knees get treated?"
Curved knees or bow legs basically is a part and parcel of new osteoarthritis. If you can make out, Indians are very prone to curved knees. You can see if you make a person stand in the front and there's a bowing of the legs. In fact, it predisposes us to a premature osteoarthritis. So ideally, if somebody diagnoses that thing and if it is outside the normal range, maybe about 4 to 5 degrees, more than what we expect and accept, I think a procedure called osteotomy is must to make the leg straight and delay the onset of osteoarthritis. We have seen people knowing that they have curved knees since the childhood, but the moment they reach 40s and 50s, even 40s, 35 and 40s, they have early onset of osteoarthritis. So yes, they can be treated. So there are two different things. Osteotomy is a procedure which basically means surgically redesigning the alignment of the shin bone of the tibia so that the mechanical axis or the line of weight bearing falls on the outer part of the knee. So it reduces the onset of osteoarthritis. But if somebody has already developed severe osteoarthritis and has curved knees in combination, then both things can be tackled by the knee replacement in one go.
All right, sir. Sir, there is one more question about from Aishwarya. He says, "What else can be done for knee arthritis besides surgery?"
Yes, so we start with grade-wise management. If a person comes to very early stage, people are becoming very conscious of their problems these days. People who are who are into sports, who are into a lot of physical activity, we see that these are the people who catch their problem early. They come to you at a stage which is much early because their normal activities of daily living are hampered. Somebody playing golf, somebody is into swimming, some things like that. And you initially start with the combination of very basic anti-inflammatories. Anti-inflammatories, the basic first medication would be a paracetamol, which has to be started. Of course, it has to be started under the supervision of your orthopedic surgeon. We cannot take over the counter. And in combination with holistic management, the holistic management would be good amount of exercise schedule in which you strengthen the muscles of the front of the knee, the back of the knee, the quadriceps, the hamstrings, the hip strengthening, increase your protein intake. We Indians are very highly deficient of proteins. Our whole food is always full of carbs, carbs and carbs and carbs. So I see, if you see, calculate your daily protein intake, it is hardly reaching even half the requirement. So I always tell patients to give more importance to their protein intake, good amount of exercise, regular walks, and more holistic management that is thing. And if pains have started to a level where grade 1, grade 2 has set in, I would advise them not to sit on the floor, not to sit cross-legged, not to squat, not to do lunges, some activities which actually aggravate the pain. They can go into low impact exercises like swimming or standing cycling or a static cycling, but jogging and running, these are strict no for people who are already into the knee pains. Plus, then if medications don't help, there's a pain ladder we have. A ladder is basically designed by WHO, and we follow that to the hilt. And the purpose is to go one by one on the pain medications. People are very wary of taking pain medications, so we have supplements, and there are a lot of nutraceuticals which have come into the market now, which basically give anti-inflammatory effect. So these can be prescribed for as long as 2 to 3 months. Basic medications like glucosamine and chondroitin have to be started at early stages. These have been proven to give some pain relief initially. So pain should be used painkillers or NSAIDs or non-steroidal anti-inflammatories only for SOS basis. We will suggest more of holistic management and lifestyle management.
All right, sir. Thank you for that. I think the pain ladder is also something that we haven't really heard about before. So that is something new for us as well to know about, to find out about. Sir, there is a question from another Praveen. He says, is there any harm in waiting even after being suggested knee surgery? I think this is again, a lot of people have this question on their minds. So, how long can you wait, or is there any harm specifically?
So I'll give that by a research which came, a paper which came. So we have seen that Asian populations, I would say of Asia because we stay in Asia, it's not common to India. Southeast Asia, Bangladesh, Pakistan, Indians mostly we like to wait. So one suggestion is not enough for a doctor, for a patient to decide. We have patients who have showed all their prescriptions of knee replacement for as many as 15 to 20 consultations with different doctors. So they are only waiting for one doctor who can say that maybe this doctor will not suggest knee replacement. So waiting can actually prolong the rehabilitation process if you take a call late. So the process of coming back to normalcy can be delayed by as long as 2 years. So best is to take, if you have to take opinions, take 2 to 3. I think that is a good time. Taking multiple opinions doesn't matter, doesn't help you at all. And waiting can be done as long as you are doing good exercises, good strengthening of the muscles. So even if little bit of arthritis is visible on the X-ray, although it is bone on bone arthritis, there is hardly any cartilage left. Good muscles will support you in the sense that they act like struts, they act like pillars in front of the knee and back of the knee, and they'll be able to sustain you. We have seen that most males, most gentlemen, they do better with bad X-rays as compared to the ladies, because as mentioned, there are multiple issues, and most of our knee replacement patients are ladies. So 80% of any knee replacement series or whenever the numbers are compared, 80% are always the ladies, and the problem also affects them more.
Okay, all right. That's again good. I mean, statistics that we have here to show how common this is actually, and how seriously it should be taken. So there is a question from Soumya. She says, if one is having increased uric acid level on regular checkup and no such joint pain, does she need to undergo any orthopedics consultation or any other advice that you might have if there is just like she's saying an increase in uric acid? But otherwise there is no other such.
So uric acid is a byproduct of normal metabolism. There's a range of which is basically 2.5 to 7 milligram per deciliter. For males, it is 7. For females, it is 6. And for so anything above the 6 in ladies and for gentlemen above 7 is high. If it is a recent high, we would like to treat them with some dietary modifications which we call low purine diet. Purines are the substances which by metabolism create the uric acid in the blood. If you can take care of that, which is a lot of beans and pulses like rajma and lobia and spinach, tomatoes, red meats, alcohols. Once you reduce them, most of the people are able to go back to normalcy. If it is a sustained high, then you have to add some medications for that for reducing the uric acid. And that's why basically it is a treatable issue. But and also dehydration, less of water intake is also one of the reasons. We have to rule out kidney problems, which can also lead to high uric acid. And if they are on high modern days, people are highly on extra protein in the form of whey protein. These people we see a lot having high uric acid also.
Okay. So as for you, then it should be looked into, it should be checked just to make sure that there is no other condition as such. All right. So then actually there is another question that we have, and it sort of coincides with one more question that we received from the audience. So I will combine those questions. One common myth that we've often heard is that again a lot of people believe that they will be put on bed rest after surgery, and also they may not be able to resume their activities like they would have otherwise. Maybe in with respect to different activities, whether it's walking, running, or swimming, other such activities. So the question that we received from the audience is from Ayushi, and she is asking for whether there are any specific do's and don'ts after total knee replacement. So if you could maybe answer both of these questions because they're sort of interrelated.
So I'll answer your first one first, and that is basically putting on bed rest. That is pure myth. A lot of people do tell us, "Am I going to be bedridden after the replacement?" This is a very common question we get, and nothing could be far from that, because most of the patients they know that once they have been implanted with the joint, they are made to stand the second day of surgery. Sometimes the day, same day, evening, or the next day. Of course, standing is not the same as regular activities, but they are made to stand at least once in the morning. And before they discharge, they actually go to the loo, they go to the washroom, they make a round of the corridor. Some motivated patients even do stair climbing and stair descent. So the whole purpose of surgery is to make you mobile, to make you independent, to bring your lifestyle back. It's a lifestyle surgery. But all said and done, you have to understand replacement is only putting some metallic parts in the joint, changing the surface of the arthritic joint. Your muscles are the same, your ligaments are the same, your willpower is the same. So, hoping as if some magic is going to happen in a day or two is a bit too much. We tell our patients, for patients who are doing for knee replacement, there's a time frame you have to evolve. That could be as less as 6 weeks for patients who have decided early to as long as 3 months. And that is the time they have to give for the replacement to actually give you beneficial effects over a long run. And the second question was about do's and don'ts. So do's are continue walking, do not sit at home once you reach home. Exercises are very important. In fact, early mobilization is very important because there are some side effects of the procedure like formation of blood clots in the veins, because if you put a patient who has been mobile suddenly on the bed for 2 3 days, the person can have something like a clot formation in the veins. So to circumvent that, we ask our patients to mobilize as early as possible. And secondly, we also give them medications for not having these clots. There are specific medications being given. So basically, do's are being active, being having a good, balanced, nutritious diet, and don'ts are basically 2 to 3 that we tell them before the surgery that they should avoid sitting on the floor, sitting cross-legged, and that's we would also advise them not to engage in very high impact sports if they have been in, because when you can do that, it's not that you can't do, but then the wear and tear of the implant, it might happen at a more faster pace, which can create an issue for you later.
All right, so there was quite a few helpful tips that you have shared. So there is one other question from Sanjay. He says, "How much help will I need when I come back home after knee replacement surgery? Do I need to rearrange my house, or will I need any other supplies after surgery?"
So when the patients are in the hospital, they are very comfortable because everybody's been taking care, nursing care is there, doctors are there. So going to the home is a big issue all the time because patients are always thinking they are being left in the lurch. And we in India, we do not have a nursing care system where somebody takes care of you at home. So first question which we get is how do we take the patient back home? How do we take transport from ground floor to first floor to second floor? So there are stretchers, there are seating arrangements by which you can be taken up. Bed, normal beds suffice, but the bed has to be a bit high. If a low bed is there, then the patient finds it difficult to mobilize himself or herself from the bed to the loo or going back. So you can imagine if your bed is high, the knee gets less pressure on getting up. Then walkers is something which is available for people who have washrooms which are very far away from the seating from the patient where he's resting. Sometimes people are advised to use commode chairs so that the walking is reduced, but that is purely for very, very few cases. We want patients to go live the normal life, go to the washrooms and lose. For commodes, which are very low in seating, very low because if you have a low commode position, then the knee bends too much. And once you want to get up, there's a lot of pressure on the joint. So there's a commode raiser by which you can increase the height of the commode. So all these things can be taken care of, and we would advise some physiotherapy to take care at home. Although patients, if they are motivated enough, they can manage on their own. But some 2 to 3 weeks therapy does help initially.
Right, so like you said, physiotherapy does play a very important role in general. And I think all of these tips that you shared after surgery that people should keep in mind are going to be very important points to note, especially for anyone considering knee replacement surgery. So we have one last question, which is basically around the fear of getting COVID when going in for a knee replacement surgery. That is something that I'm sure you must have come across in the past as well. And if you can maybe explain how justified this fear is, there is, I mean, I would not say that there is no fear or no risk. There is a certain fear, but if you can maybe help sort of reassure people about whether they should go ahead with knee replacement surgery at the time of the pandemic.
So what when you say pandemic, we are basically shifting from a pandemic mode to endemic mode. As everybody has mentioned, as all experts have mentioned, we have to live with the virus, and it does surprise us sometimes. It has surprised us twice. We we think there might be a third one coming, which we are not sure about. So I would say if your pain is severe and your lifestyle has been affected to a level that your normal activities of daily living have gone for a toss, basic thing like getting from the bed to the loo and coming back from the loo to the bed, basic things like basic activities of daily living which you used to do with ease have become so troublesome. Or else you have to take a pain medication every day to just maintain it, or you are having everyday morning stiffness of half to 1 hour. You are in the zone for a replacement. Only thing is, what are the hospitals doing? Hospitals are doing everything possible. They maintain all the standards of which are required from a hospital. We ensure universal masking for all the people who are coming inside. All sitting zones, all patient waiting areas have distancing protocols. All patients are subjected to a preoperative RT-PCR for COVID-19, which is basically a way to find and the patient knows beforehand. Uh, if at all things have been at a stage when you have COVID patients in the hospital, they are segregated. They are kept in a separate floor. They do not merge with the general population. All entry exit zones are separate. So I don't think that concern should be there because we have seen both the phases, both the waves have hit people very badly, and patients coming now, they tell us that they have been waiting for this at least for a year and a half to 2 years, and COVID has set them back by a long. And once you do a replacement, I tell patients my job is 70-75%. It is 20-25% is all yours. It is how exercise you do, how mobile you have been. So patients who used to walk into our clinics now they come on wheelchairs. People who were on wheelchairs they come on a stretcher. and the expectation is the same for everybody that they are going to be mobile the second day of surgery. So everybody has a different pain thing. Everybody has a different preoperative protocol and a postoperative protocol. So this is how it is. So I think that fears are unfounded. We all we all face it, but if at all you have to go, you have to go for it. There's no point waiting anymore.
Right, sir. And I think that might be the best way out for anyone suffering from intense pain and who is not able to move around that much. And like you rightly said, sir, it's team effort between the doctor and the patient as well. 75% is your effort, and then 30% or so has to be done by the patient as well. Sir, we've really enjoyed this discussion with you. I think we've all gotten quite a few answers to all of our questions. So thank you so much, sir, for sharing your thoughts with us and being a part of this discussion.
Thank you, Sachin. Thank you for having me. Thank you.
Thank you, sir. For our audience, if you have any other questions, you can leave us a comment on Facebook, Instagram, or Twitter, or on YouTube, and we will get back to you by the end of the day with all the answers. Thank you.
Okay. Thank you. Thank you so much.